Say, uh, hi everyone. While we're getting ready, I just want to say first off, thank you for what you do, being the front line while we comfortably sit a step behind you. But yeah, no, we appreciate it. This talk, I feel like, picks up where my colleagues and myself have left off previously. We've previously talked about basics of heart failure. We talked about shocks, and I believe Chris talked about shocks and what to do about them. This kind of goes into the advanced heart failure part. So let's start. So we're going to review a little bit at the beginning, but then quickly transition. I know you all know about this, which is the classifications where you have the NYHA on the right side and then the ACC on the left. NYHA focuses purely on symptomatology, while your ACC classifications are progressive only. They don't revert back, and they have a structural component and to some extent some symptomatology. The reason I included the thing on the bottom is because the importance of understanding heart failure is that you have to understand what the reasoning behind this heart failure is. And the sooner you catch it before the progression, the more likelihood you have of either reverting back to normal, keeping them at where they are, and help decrease the chance of progression, and at least symptomatically, I'm having a speech impediment here, keeping them where they should be, or getting them to prevent reverse remodeling, as you see on there. So as you transition more through the ACC classifications, as you see drawn out there, you go from just remodeling to reverse remodeling, and that reverse remodeling, a lot of it becomes permanent. So that's the whole reason we harp on heart failure. And you see plenty of these patients in the hospital anyways. So what is the etiology for heart failure? As you can see here, and as I know you guys had a chalk talk about this recently, ischemic cardiomyopathy makes up 70%. This is important to understand because one of the things you need to look for heart failure is ischemic, or at some point they should have had some ischemic workup. Hypertension makes a good percentage, about like 7 to 8%. You see a lot of other risk factors, including thyroid, HIV, and some of the other things that are written there. Realize with alcohol that's mentioned there, it is severe alcohol use for at least about 5 years or more. So it's not someone that's binge drinking today. I know some of you might be relieved that that might be a good news for you. So moving on from that, I know you're all aware of this. This is a very ugly looking chart that our great ACC has provided us for heart failure management. As you are all aware, and from our previous discussion, a patient comes in with heart failure. That patient should be on an ACE or an ARB. That patient should be on a beta blocker and diuretic. ACE or an ARB and a beta blocker, that's decreasing morbidity and mortality like we discussed previously. The other thing I want to mention to you, and the thing that's lined up here for you, is that the ACC at least has moved away and kind of made it okay that as long as the patient's in NYHA class 2 and after, I'm getting feedback.
I turned off my mic.
Okay. So as long as that's the NYHA class 2 and after, you can think of ARNI instead of ACE or an ARB, even as a starting agent. That's your Entresto. The other thing is starting the aldosterone antagonist sooner rather than later, as long as it's something that can actually happen, as long as their creatinine clearance is not too low or their K is not too elevated. Realize in our Black patients, Bidil, the hydrazine nitrate combo, does have morbidity mortality effect. Personally, though, I know it's very difficult for a majority of our patients. Personally speaking, I have a hard time taking a single medication a day, let alone taking something that's 3 times a day. Doesn't sound that much fun. In here, you have an indication for ICD and CRT. So what is the ICD recommendations? Realistically, anyone with an NYHA 2 to 3 and an EF less than 35 with a greater than 1 year survival should have an ICD-1. If their survival is less than a year because of, let's say, cancer, primary pulmonary disease, other reasonings, it does not make sense for that patient to get this because that's one. The other thing is if their heart failure is very advanced, realize that they can go in a lot of non-sustained VTs or VT-based episodes, and so they might just get shocked repetitively. That's why it's NYHA class 2 and 3 that's mentioned there realistically. Again, realize those patients are patients on guideline-determined therapy that have an EF of less than this, because we have a lot of patients that have cocaine abuse, non-compliance, and whatnot that we sometimes get called upon. And I'm not saying sometimes we do decide to give them an ICD, but realistically, this should be at least on 3 months or 90 days of guideline determined medical therapy or correct therapy post-MI with a low EF after 40 days. CRT, similar thing. The only thing being is that there's a left bundle in addition with a QRS complex of 150 or more. And ivabradine is the patient you've maximized beta blockade on, and you've either been limited because you're at max dose, or you've been limited because the patient is getting hypotensive, and they're in sinus. Then you can consider if their heart rate is above 70 to start ivabradine. It's a iFunny channel, affects more the K than sodium, but that's how that medication works. And then, like you see in the second step 4 and step 5 is where this talk will mostly take over, which is consideration of whether we want to do what other advanced therapies we want. And this is, a lot of it is what can be available to that patient with their comorbidities and other things that are occurring. And also, what is the patient's wishes? So we go based on both of these. And our goal is to make them feel better and possibly give them a longer, meaningful life. So Chris went over this. If since I have someone that wants to do palm crit, I'll have him fill this out kindly. So if you don't mind, we're going to talk about the different types of shock. The importance of this chart is really why do we do the difference in management when you're talking about shock, and how does different shock change the different factors? So on what's mentioned here is cardiac output, SVR, and wedge. I'll help you along with this, but if you don't mind, if both of you can assist me, or people on the chat, if you can write, what do you expect with cardiogenic? And that's I think the easiest one.
So cardiac output, SVR, and whatnot.
Yes.
Cardiogenic, I mean, obviously cardiac output that's the primary issue.
Yes.
SVR is going to be increased if no one can compensate for that or attempt to compensate.
Perfect.
It's going to be up because there's essentially backup. The pump is always just backup.
Perfect. So just to quickly repeat, because I'm not sure how well you guys can hear him, with a cardiogenic, you expect your cardiac output to be decreased. That's leading to this whole shock component. Your body's trying to compensate and increases the SVR to maintain a MAP. Because of this elevated SVR and a decreased function in your cardiac output, you then have an elevated pressures that are sitting in your LVEDP. In addition to this, your heart is by itself probably not pumping as well as on top of that, so you're not emptying as well. So that's what's leading to this. What is obstructive shock? What is that realistic? Yes. Perfect. So PE and tamponade. So what is difference between that and a cardiogenic component?
I think the difference most notable would be on SVR.
Your body's still trying to compensate. You're right. So you have a slightly less of an SVR. You still have an elevated wedge because if you think of a tamponade, at least, you have a fluid within the two sacs or between the sacs. So you're actually not able to build up that pressure, but you're not also able to empty as well. So you're going to have a higher baseline pressures that are going to sit there and a similar consistent diastolic pressures throughout. And so that's the only difference. It's pretty much very similar to your cardiogenic component. Hypovolemic, this is easy.
Down. So cardiac output is going to be trying to compensate. SVR is going to be a wedge.
Okay. So you said something, and you're not incorrect. So I want to just quickly point out. So you said cardiac output would actually be high. SVR would be high, and I agree with you there, and a wedge would be low. Why does it say down for hypovolemic then?
For cardiac output?
Yes.
Your stroke volume, your cardiac output is 100.
So exactly. So at the beginning, before you go to a legitimate shock component, your cardiac output is actually going to try to increase because your heart rate is going to go through the roof as a compensation. Your stroke volume is going to be slightly down and it's going to compete. So it's going to be neutral, maybe slightly up. But when you get to the shock component, you're actually going to be low. So that's why it's actually pointed as down. And the reason being is your heart rate is picking up, but your stroke volume is pretty down and it's not compensating well enough for that. Neurogenic. So there's something interesting about this. So I want to see if you can, so all these are kind of similar. So think of septic. What is septic? Okay, so what would you expect for these numbers for? Mhm. You're right. Yes,
Your SVR would be down.
that's correct. Yeah, so it's kind of like hypovolemic. The only difference, like you said, the reason they're saying cardiac output can be high or low, you're right. Majority of the time, you think of it as a hyperdynamic state. So you actually usually expect your septic shock to have an elevated cardiac output, like you mentioned correctly. The only reason it's putting questionable down is because when your SVR, if it's going so low that you might not have enough preload, and with that, you might have a similar thing with a stroke volume effect that we discussed with hypovolemic.
You're not getting any deuce returns. You're not.
Yes, but that's the patient that's fully crashing and not your typical septic shock. Your septic shock, like you mentioned, you expect the cardiac output to be increased. What's cool or interesting to me about neurogenic is very similar to your septic, and I remember it very, very much the same. The only thing that's different, your septic, what do you expect with your heart rate? Neurogenic is the only one where you're going down and it makes no sense because you're not appropriately compensating. You would think if you're vasodilating, which neurogenic is doing, you would expect your heart rate to increase to compensate, but it's not because it's a neurogenic component. You actually get a decreased heart rate. So that's the only fun caveat to this. This picture you have all seen, so I hope by now all of you can look at a heart failure patient and be able to box them in warm and dry, warm and wet, cold and dry, and cold and wet. Why is this so important is because your management should be very different where this patient falls, right? So if you have a patient that's warm and dry, that's probably a clinic patient, shouldn't really be in the hospital. If they are, should be discharged probably soon, maybe medically optimized and then discharged. Warm and wet is your typical medicine-based admissions, right, that you have. You're diuresing them, making sure their medications are optimized, and then discharge them. Where your cold comes in is that's when at minimum cardiology should be involved, and probably that patient should be sitting in CVICU, right? Your pump is not appropriately compensating. And I'll tell you, if I had to take a preference between cold and wet and cold and dry, personally, I prefer cold and wet. And the reason being is a lot of times when you diurese them, you can get them back to a normal curve and bring them out of this. Cold and dry, if it's legitimate cold and dry, you might be able to give them a small bolus of fluids and see how they compensate. And if they get better, great. But if they don't, those patients are probably going to be discharged with some kind of either ionotrope or going to get worked up for an LVAD or need transplant, need something, right? So again, that's how I kind of would divide it. And on the left, you see the differences on some of the differences on management on what you would do. Not much of a difference other than the fact that where you're putting them, what level of medication you're starting on. Again, if the patient is cold, I would hope you're not giving them a beta blocker in an immediate setting, right? Because not only are they coming with heart failure, exacerbation, and shock, beta blockers are not probably your best bet because you're going to probably start them on some kind of a ionotropic agent, whether that's Marinone or dobutamine or whatnot. That's something to keep in mind. Also, let me back up to this picture one more time. This happens often. Realize a lot of patients with heart failure have atrial fibrillation. So I sometimes will get a call from medicine while at night or during the day saying, hey, we have a patient has atrial fibrillation, they're in our VR, and we just gave them X amount of beta blocker. Oh, and just as a fun note, they have an EF of 15%. Just realize that gives me atrial fibrillation, and you might need a beta blocker on me right afterwards. The reason being is you really want to look at their EF, assess them clinically, and see, is this a cardiogenic shock that's leading to a tachyarrhythmia and causing this? Or is this a stable heart failure, no heart failure symptomatology, they're compensated and just went to atrial fibrillation? Because if it's that patient, I agree with you. Beta blockade them and we'll monitor from there. But if it's actually the patient that is in heart failure and has incidentally also gone to atrial fibrillation with RVR, there's a good chance that patient's then now going to be sitting in CVICU, even if they needed it or not needed it beforehand. All right, so this is mentioning some of the ionotropic agents that we have. Dopamine, it talks about the time of action, like how the halftime, which I think is very important for you to understand. We normally use either dobutamine or Myrno. Realize that your Myrno take a long time to actually kick in. This is why a lot of times when we started, if we have swans in, we don't check repeat numbers for 3, sometimes 6 hours. It has a renal component. So if the patient has a bad CKD, a lot of times we try to hold off on starting Myrno, but also realize it might take much longer for it to actually clear out appropriately. All right, what is advanced heart failure? I think we all know it, because when you see a patient that has been on optimal medical therapy, is compliant, their blood pressure is not allowing you to either up-titrate meds or you have to take off meds because of blood pressure. Their BUN and creatinine is rising. Their BNP continuously go through the roof. Their systolic blood pressure is in the 90s. They keep coming back and forth, and it's not because they're not taking things. It's because their heart is failing. I feel like when you see these patients, you know who they are. And also sometimes frequent ICD shocks. This is your advanced heart failure. This is where hopefully by now this patient has seen a cardiologist. If not, they definitely need to see a cardiologist, and probably also seeing a heart failure team at some point, whether inpatient or outpatient, sooner rather than later, because we need to consider what to do. Moving on from this, this graph, I actually really like this graph because it kind of talks about the quality of life that these patients see and their intensity of care, and when we sometimes transition from aggressive medical therapy to palliation, and the importance of consideration of palliation, because you want to give the patient what they need and not what you want for them. So quality of life, as you can see with a new onset CHF, it goes through its own clinical course. Sometimes you can actually help prevent further progression, like I was talking about, by figuring out what's causing it and possibly reversing it. In some patients, you have sudden death, and they sometimes come back from that, and you're seeing them a second time, so a CHF patient with sudden death. And then a lot of times what you will see normally is yo-yoing in and out. So you give them correct medical therapy, you discharge them, they get either they get bus to follow up or they follow up, and they're having repetitive like events of heart failure exacerbations. And as you can see, their quality of life is going down as these things are progressing. So when you're getting closer to the advanced region is where you really need to consider, hopefully a little bit before that, what therapy or what way you want to progress. Is this a patient that wants aggressive therapy, and is this a patient that can get aggressive therapy? There's a lot of factors that go into this, whether it's socioeconomic status, their overall, again, comorbidities and other things that they might have. And then you decide which route, whether that's palliation that's being increased or traditional medical care. This is the quick summary of the guidelines for these patients. Realize that ionotropic agents in a prolonged term, they decrease life expectancy, they improve symptomatology. So that's why this is why we don't actually recommend prolonged ionotropic use unless it's a patient that's on palliative, that wants palliative related care in a prolonged time. In shock, we always start it. And that, as you can see, that's a class 1 indication. I will get into when we consider and the types of circulatory support systems we use, and then transplantation. So I know for whoever has been at CVICU, especially on Team B now, we talk about intermax profile. So the only quick thing I want you to know, and I don't need you to memorize this because this is not for your boards. Class 1 through 3, these patients need to be at minimum with an inotrope or a device that's pumping for them. So these patients are patients we are working up for either palliative, or they're getting worked up for, or they're getting soon an LVAD, or getting worked up for an LVAD, or getting worked up for a transplant. Class 4 to 5, they don't really need active inotropes, but they can go in and out of needing your inotropic agents with exacerbations and hopefully weaned off of it slowly and discharged. And 6 and 7 is practically, 7 is every other patient, and 6 is your class D, but has symptoms basically at baseline. So, transplant algorithm, right? So, when do we consider listing patients for transplant? Realistically, a patient in class Intermax 1 through 3, I'm thinking about one of these things, whether it's permanent, like destination therapy, MCS, which is mechanical circulatory support systems like an LVAD, or temporary at minimum as a bridge to a transplant or a possible transplant, or inotropic before one of these things, or for palliative. Class 4 is realistically when we start thinking about this process. Class 1 to 3 is when we start initiating this process, and then the rest is guideline-determined medical therapy, as you can imagine. Okay, so heart transplant. Realize as time progresses, we're becoming much better with transplant, and their survival is increasing. There are new techniques which we're using, and it's not really new, it's since 1980s that we're using the similar technique, but it's our newer technique, which is the bicable technique. As you can see from this data, they have good survival. If you look at the purple graph, basically that's since 2009 and after. These patients have around 60-75% survival even after 5 years. And if you look, in general, we say there's greater than 50% survival post-transplant within 5 years. So there is good numbers. As you can see, median survival in current era is 12.4 years. Realize the thing that complicates this is either inappropriate match, non-compliant patient. This is why a lot of the socioeconomic compliance issues really needs to be hashed out beforehand, because you're using someone else's heart and you would hope that it goes to the best person with the best chance to make a difference. So that's why there's a lot of things we do beforehand, whether that's a right heart cath, echo, and other considerations that we do.
What are they dying of? Are they dying of heart palpitations?
Yes. So usually you have, whether it's the acute rejection, people that have acute rejection, a lot of times that resolves with appropriate therapy. Having said that, a lot of those patients then sometimes develop vasculopathy, secondary to both immunosuppressive therapy, their rejection episodes, and other things, and just atherosclerosis on itself, because these patients are more than likely ischemic in origin and have higher propensity to have these issues anyways. So, but yes, it's repeat heart failure. I really wouldn't know. Sorry. So now to this. I know if you've been with me in CVICU, I've brought this conversation up multiple times. I'll get on the board and we'll kind of talk about this. Hopefully I have a working marker or a marker. Does this work? Nope. So. Okay. So, to understand, at least when you're in CVICU, what devices we use, you need to kind of understand what they do and how they affect the body in general, right? So, sorry, give me a second while I get a marker. I don't think. What's up?
Gene's working on it.
Okay.
Good.
What?
What happened?
Fires.
You'd be good at that. So hold on, let's try it.
What's up, Natalie? Oh my God, it's so nice to see everyone. Put your mask on.
Thanks, brother. Oh, working? Yeah, that does work.
Yeah.
So, what are the types of devices that you guys know that can be utilized in someone, let's say, with cardiogenic shock that we use? Okay.
Balloon pump.
Balloon pump. Fair. By the way, he said echopella. What is he talking about?
Impella. Echopella is in.
No, so you said a correct statement. That's two things combined. That's an ECMO and an impella. So we do use an echopella. It's just that, see, he wanted to be advanced. He wanted to beat everyone else that's cardiology driven in here. Intra-aortic balloon pump, an impella, ECMO, and just to be specific, this is a VA ECMO, not for Veterans Affairs, but for basically this has a venous and an arterial, because a VV ECMO is what our Palm Crit colleagues use, and that's boring. Why would you get there? So we're going to talk about a VA ECMO. What else?
Talk about acutely or chronically?
Oh, that beautiful. I'm going to focus on this, and I'm going to go in through this in order. Balloon pump. Sorry, if my drawing is bad, I already apologize. Can somebody kindly explain to me what a balloon pump is and what it does? Not all at once.
Does it inflate during diastole, filling, and then deflate during systole, reducing afterload?
Sure. So we had a proposed mechanism of in systole that it would actually deflate, and in diastole it would inflate. Do we all agree with that? Getting a thumbs up. Matt is, I don't know what he's doing here. And yes, I think maybe that is correct. So why do we do this? And you said it appropriately. So like you said, in systole, it's deflate. The thought process behind it is that when it deflates, it provides a suction effect, decreasing afterload. So we think it has a very minimal afterload effect. And then in addition, does it affect cardiac output? Minimally, about 0.5. That's the max that it can probably provide. So realistically, yes, it increases it minimally at best. The other thing you mentioned, this is why we put in a lot of patients that have ischemic cardiomyopathy. Can you guys not see this?
You're fine.
Okay. Sorry guys if you can't see it, but I'll try to write bigger so you can see. So cardiac output about 0.5 and decrease in afterload. And like you brought up, the reason we use this commonly in our ischemic patients, either as a temporary bridge before they get, let's say, in coronary artery disease when they're in shock and they're pending open heart surgery, CABG. We a lot of times leave these in, or temporary after a cath with stented lesions. The reason being is it, like we just said, it actually inflates during diastole. What it's thought to do is it actually helps fill those coronaries. So you have a bigger pull coming back into your cusps with the thought that this is filling your coronaries. So you're decreasing the work on your heart, filling the coronaries better, and that's how it's thought to work. So that's one of our devices. Impella and LVAD, I'll combine to one. I'll tell you how they're different, but realistically, in the mechanism-wise, they're very similar. So can somebody explain to me how it works? Before we get there, I'm going to talk about what I talk to everyone about, is that I feel like since med school, we get taught cardiovascular physiology a little bit wrong. And the reason I say this is, when I say preload, everyone expects me to say preload, which is the RV-based preload. And when I say afterload, everyone automatically jumps into what the LV sees. Realize that you have two sides of your heart working in series. So again, you have a heart which is your right-sided, and you have a heart that's your left-sided. This side has a preload. This side has an afterload. And similarly, on your right side, there's an afterload. And this side also has a preload. Why does this matter? Because the whole thought process behind an LVAD, or let's say an Impella, you have to understand what's going on with that patient and what is happening. Because you can have further complications post-insertion because you didn't think about this like through. So how do these things work? The Impella and LVAD, what are they technically doing? So this is my very bad drawing of an LV, let's say. So let's say you're placing this in a left ventricle. You can do it for a right side as well. So let's say this is your aortic valve and mitral valve. This is an Impella. It's a tube that sits here. It sits in kind of like mid-cavity. It sucks blood from your LV and shoots it out into your, basically, aorta, right? Now, as you can imagine, if that's pushed in too deep, it's going to be sitting in the LV. What happens if you suck from the LV and push into the LV? Not only are you not doing anything, but you're lysing the blood. So it's really good if you want hemolysis. Not really good if you're actually trying to get something meaningful out of this device. Similarly with an LVAD, LVAD sits here. So it's, imagine there's a apical cannulation. And then it attaches to your aorta. So you're sucking blood out and pushing it into the aorta, right? So the overall physiology might not exactly be the same. The thought process behind both is very similar. With that being said, what are the things we look for in these patients? Before we consider any of these things, what are some of the things we might consider?
RV function.
Thank you. Why RV function?
Because you're gonna increase the preload on your RV and potentially cause issue.
Fair. Anything else? I'll get to that point. You're correct. I'll get to that point. Pulmonary hypertension, again, similar thought process than what you just brought up, but because in that case, your afterload is so much on your RV. So your RV afterload is so elevated. And is that going to lead to further problems once you put a pump in? And the reason being is, think about it this way. When I put a pump into your LV, you fix the problem in your left ventricle. So what does that do? You're going to suck blood out and pump it at whatever amount you want. That can be as much of an augmentation of your index as you would want, cardiac index. And you're pumping it throughout. So what is that going to do to my preload on the RV? That's going to go through the roof, right? Because now your heart is functioning and it's finally seeing that whole 5 liters and some that's shoving into it. And if it doesn't pump well, what's going to happen? It's going to fail further. That's going to back up further. Your kidneys are going to fail. You're going to have your liver enzymes are going to go through the roof because there's severe congestion secondary to that, right? So Dr. Corlon, a lot of times when he has new residents rotating with him, likes to ask one question. If I put an Impella or a VAD in someone, does that improve RV function or decrease or kind of like damage the RV function? That's a trick question. That's a really bad trick question. Reason being is it really depends. If this patient has a fixed pulmonary hypertension, what does that mean? That means they have bad primary pulmonary hypertension that stayed there for a long, long period of time, or they've had a bad left-sided pulmonary hypertension, which is WHO class 2 pulmonary hypertension. That's been there for a long time. They can have irreversible changes in their vasculature. So if there is a fix, which means I give them nitroprusside and other afterload reducing agents and remove that LV strain that normally has, and that doesn't improve that pulmonary pressures that you see, more than likely that's a fixed pressure. And if it's fixed, that RV is seeing that pressure on top of it, no matter what. So if you open up this whole preload by making the left side pump efficiently, that's all going to get there and possibly back up and cause further RV failure. Now, if the RV failure temporary is because of the fact that, let's say, they had temporary ischemic disease or RV failure because of an immediate LV failure, if you put a pump in, you fix that problem because you're removing the afterload that the RV at that point is seeing. And since you're removing that afterload, because your LV is now functioning, it's going to go back to normal. It's very resilient in picking up its function and going back to normal. Does that make sense? Okay. So this is why these patients get worked up so much, because we want to make sure if there's RV failure, first off, if there is RV failure, and if yes, what's causing it? And how is it fixed or is it temporary? And this is why when you see, we ask you guys sometimes, send the patient for a right heart cath, we want a nitroprusside challenge. I'm trying to see if I remove this whole left-sided elevated pressures and work, whether that normalizes the pressures in the pulmonary vascular pressure. Sometimes it does it slightly, but not completely. And if it's slightly, these patients a lot of times would benefit from an LVAD as a bridge transplant because it gives the vasculature enough time for them to normalize their pulmonary vascular resistance. And when they normalize, then they become an actual transplant candidate, where they might not be beforehand. Because if you put a fresh heart in someone with a bad pulmonary hypertension, they're going to get that heart, and then their RV will fail, and they will probably fail. Right? So now, any questions so far? If yes, would you mind typing it? While you're typing questions, I want to also bring up a point I forgot to bring up regarding a balloon pump. If you remember, this is our vessels, this is the renal artery here. The balloon sits between these two. If I shove a balloon too high up, so let's say you're in the MICU or CVICU, more than likely CVICU, and the patient has a balloon pump that accidentally got shoved in. That patient can become altered. Why? Stroke, or you're inflating into the carotid, like by the carotids. And if you're not getting enough flow there, guess what? That patient is going to be slightly more altered or demented just because of flow. The other thing is, if it gets pulled back, it can go at the level of renal arteries. A similar thing, except they're going to have worsening renal function. So you're going to have someone coming to you and be like, the patient no longer urinates, and they were urinating perfectly fine. So this is why a lot of times you'll see us order x-rays and see where the level that the device falls in and whether it's too high or too low. And we decide which one, whether we're going to pull or push accordingly once we get those. Any questions? If not, I'm going to move to ECMO.
Yeah, there's one question.
What's up?
It looks like Danny says, so essentially Impella will worsen if there is intrinsic, irreversible RV disease or irreversibly elevated pulmonary pressure is resistant.
Yes. If that is a fixed pulmonary pressure that's elevated, yes. That's why, again, a lot of times, at least with LVADs, we do a full workup beforehand to make sure that's not a fixed pulmonary hypertension. If it is a temporary, like in the cath lab, the patient has a stent placed and they either code, arrest, or the ballooning takes a long time. They sometimes place it, and the reason they don't check is because it was a very quick temporary measure, and they assume that the RV is functioning fine, or to most extent fine. Okay. What is an ECMO, right? I would hope by now many of you guys have seen an ECMO device, right? So we have, again, sorry, let me just back up. With an Impella and LVAD, you're directly affecting the LV, or the left-sided stuff. Or if you place it on the right, you're affecting directly the right-sided stuff. So realize, whatever you do, if you place it on the left side, you're going to decrease the preload and the afterload on the right side, but you're going to increase the preload that's coming back on the right side, right? Now, how does ECMO differ in this? ECMO is like a parallel circuit you put attached to this. Why do I say this? It's in a common term, and I'm not going to specify every vessel that can be used. You'll see commonly our patients have, let's say, a femoral venous line and a femoral arterial line. Why is that important? This is sucking blood from your venous circulation in your leg and shoving it back in with about 5 liters per minute or whatever setting they put it on, going back into the arterial system. So you're shoving that amount of blood, that amount of index, to go back into your circuit that was there beforehand. Imagine the pressure that now goes on the heart. What is the pressure change that that heart is seeing now that there is an ECMO pushing against it with whatever setting, 5 liters per minute, let's say, of blood? Increase afterload. Does that make sense? Because you're taking blood from the femoral vein and shoving it at whatever you set the settings to come towards your main vasculature, right? So your heart is now seeing another heart, imagine, pump against it with that amount. So why is this important? Because realize a lot of places, except our institution, does an ECMO with an impella, what our friend here called echopella. Why is this?
Yeah.
It's to offload your LV so it doesn't further fail. So imagine you have that ischemic cardiomyopathy patient with triple vessel disease, right? Who's now coming in with this new shock picture, and you decide to put an ECMO in. If you don't offload that LV, that afterload is going to go through the roof. What does the heart do to compensate for that severely elevated afterload? So it's going to, exactly, your heart is going to try to increase cardiac output. How does the heart do that? You're increasing your heart rate a lot of times, or contractility as a way of increasing stroke volume, right? What happens on the workload of those muscles that already have a bad flowing?
You're increasing demand.
You're increasing demand on them. What is that going to do to your scarring or ischemia or infarction? You're going to make it worse.
With minimal preload.
Yes, with minimal preload. The reason being is that ECMO is, again, sucking blood out of your femoral, let's say femoral vasculature, and shoving it back into your systemic arterial system. So this is why some institutions, or a lot of institutions, do an echopella. They offload the LV this way, and then they also have the systemic flow by an ECMO that exists there. So have you guys heard of something called an ECMO lung? What is an ECMO lung? It's a colloquial term. What happens to the heart that can't beat efficiently through this increased afterload? What's going to happen to that pressure inside the heart? Imagine an LVEDP or wedge pressure. What's going to happen to it? It's going to go up. When the heart pressures go up, where does the fluid end up? Lungs serve as a dampening factor, so it actually takes the fluids, release it inside of it, and you see they have like ARDS looking X-ray or imaging because they have fluids everywhere. So this is why a lot of times we're just monitoring all these things. We are trying to see what led to this cardiogenic shock picture that the patient needed a VA ECMO on, and what are we trying to get out of it. So if the point is that this patient has bad coronary artery disease that we're going to intervene on, the ECMO makes sense, because if we go and intervene and we think this is an easily fixable intervening, then we do it, you assume the heart is going to respond, it's going to pick up where it left off and normalize to some extent, right? Or if this was a myocarditis that you think is a temporary measure, again, this is going to improve on itself. What are some of the complications you can see with our ECMO, VA ECMO? Have you had patients that have vascular compromise post-ECMO? Yes. Okay. Why does that happen? So imagine our femoral access, right? Which way does normal arterial blood flow in our legs? Yeah, it goes down to as distally as you get in your legs, right? Now, if I'm shoving a big, massive catheter that is pumping my femoral venous blood all the way into my arterial system, where's that blood going to go? It's going back to your main system. It's not going to that leg, right? So a lot of times you'll see they put distal perfusion cannulas to give blood to that distal extremity. Sometimes they can, sometimes there's a clot there already, or sometimes they develop a clot after they do this. What are benefits of an ECMO? You don't have to worry as much about what the lungs are doing, because you have a system to remove CO2 and to oxygenate. It's completely up to your choosing of how much you want to bypass the lung or take the work of the lung on top of the work of the heart. All right, we can probably go back to the PowerPoint. Any questions so far, guys?
And this is not like ECMO, but like with ED, ECMO north-south syndrome.
Sure. I'll do this right afterwards because I want to go over the pictures first. That's fine. Because I assume I'm running short on time anyways. Sorry. All right. So getting back to this PowerPoint. So hopefully this makes sense now why I have a series circuit and parallel circuit, because what you do is affecting it differently based on which system you use and when you use it. These are some of the devices we talked about. There is imaging of what they look like and where they get placed. I know my drawing was perfect, and so you should have probably figured it out, but this is a little bit better than what I drew. It also talks about Tandem Heart. I've never seen it used here at our institution. It works similarly to some extent to how an ECMO functions. The only thing is they sometimes can, what they can do, and they can do this with ECMOs as well, they can put an offloading cannula into your LA. So you pierce through, you go from the femoral vein all the way up to your IVC to the RA, and pierce through into your LA and put a cannula there that just empties out directly from that point. So this is showing you an LVAD, different types of LVAD, but quickly it's showing you, again, you have the inflow cannula, which is sitting apically, and it's getting pumped whether immediately or through a secondary thing. And just as a cool thing, these are like similar to a submarine-based propellers. They're levitating off of a place. They're not attached to anything. They're just turning with magnetic field and actually producing a flow. This one on the bottom is showing you a center mag. I'm not going to get into it, but it's similar to an LVAD. The only thing is all of its attachment points are from the outside, but they're from an inside, but it works like an ECMO. So they're like internally cannulated ECMO. We had a patient in CVICU that had this, and they got a heart, thankfully, within, I think, 3-4 days and got a transplant out of it. Again, a picture of what an Impella looks like. These things, I know you might see a lot of people that hemolyze with them. If they're placed appropriately and functioning normally and you're looking at their hemodynamics, they don't. Dr. Cook is amazing. If you see how she manages these things, it's great. LVAD survival. Why do we use LVADs? We use LVADs either as a bridge to transplant. Again, like the patients I mentioned where they can't either get a transplant because they need a device now and they're probably not going to survive if we just keep them for a long time before they get a transplant. Or as a way to reverse this pulmonary hypertension and give it time so by the time we transplant, this heart will do better. Or it's a destination therapy. And again, this is to give a patient a meaningful life, with a median survival of about 4 years. I think that's about it. I included a link. I'm going to hit it and see if this opens up and how this works. Can they see this, your screen, or no? Okay, sorry. Okay. So realize there's a Seattle heart failure model, and it's actually pretty cool if you're ever bored and have time to do this. If you actually go through, sorry, I'm waiting for it to load. And if you put in the medications the patient is on, the age that they have, what is their current weight, and all these factors, and I know there's a lot of factors, it tells you what their survival is more than likely going to be, like their overall survival and their mortality and the life expectancy. So you can see this patient is being very inappropriately treated because they're not on any meds that we should have them on other than a diuretic. And let's say you put them on an ACE inhibitor, a beta blocker, and an aldosterone antagonist, and you can see with interventions how much improvement they have over survival, mortality, and their mean life expectancy with the current things. Now you can see similarly, if their blood pressure at baseline is sitting in a non-existent number, let's say 90, you see how that affects your overall mortality, right? So without intervention, this patient has a survival, 5-year survival of 20%. And with intervention, they'll become 56%. But again, you can see how these things manage. Yes. What an ICD does and all these things. So that pretty much sums up my talk. If you guys have any other questions or anything else, please let me know.
You talked about common issues associated with LVADs like AVMs and solid blood pressure.
Sure. So a problem that we don't understand well enough what does having not like a systolic diastolic pressure, but rather a continuous pressure does in the overall vasculature bed. The thought process or one of the hypotheses is that if you have a patient that has a continuous flow and not this ranging flow, that a lot of times this can lead to some vascular damage and possibility of AVMs and bleeding later down the line. Again, this is usually a temporizing measure and not a continuous measure. Anything else? If not, thank you for listening. Thank you for what you do. Appreciate it, guys. Take care.